Okay. Alrighty. Thanks, Rose.
Oh, you can take them if you want.
Well, I'll just leave them here because I might take them. You said these are slides, right?
Yeah, those are for you.
Okay, great. And so I'll have them as things to be fair. Will I be bugging you if I sat by you?
No.
Am I in anybody's way? How do you see this thing?
Can you see? It's very weird.
Can you see this?
Oh, sorry. Can you just stand right there?
It's very weird to sit down right there.
You can sit in the clay.
I feel like the old lady in my God on the road. Y'all say, are you comfortable?
You don't see that.
It's hard. So from inside the clinic, my topic was shingles, and I'm Sarah. So the etiology of shingles is the varicella zoster virus, and this virus is usually inactive in your bodies after you have the chicken pox. But what can cause it to become active can be immunity, physical, or emotional stressors. And then individuals who have shingles, you don't pass shingles to someone else, but you could pass the chickenpox virus instead. So the symptoms include burning sensation, rashes that travel from your back to your chest, and also a fever and abdominal pain. And sometimes it can actually affect your eyes or your ears, which can cause hearing loss or vision loss. And the diagnosis, so healthcare providers can usually diagnose looking at the rash, but they can also look at the white blood cell count, and if it's elevated, that can sometimes lead to the diagnosis, and also antibodies against the chickenpox virus. So treatment includes antiviral drugs, acyclovir, fanciclovir, and valacyclovir. And the prevention, right now, they have on the inside the clinic, they have the Zostavax for individuals 50 years and up who had previously had the chickenpox virus. However, according to the CDC, Shingrix is now the preferred vaccination for 50 and up. And Miss Bat got that. And then these are the review questions. So, which virus does shingles follow? Yes. The answer is C. And then what is the etiology of the shingles virus? And then lastly, which is the name of the preferred vaccine for individuals who are 50 up in age and previously had the chickenpox? Yep. And that's it.
Do y'all have any questions for Sarah?
No, you go.
I have little handouts.
Oh,
They're really not that serious.
Oh, this looks pretty serious.
I'm really sorry. I was gonna make a cake, and it's gonna be really like gross. I was gonna have like oozy stuff coming out of it, but it's just too much. So I did. All right. Sarah, did you take yours out? Oh, no, I didn't. Thank you. We've been screwed. Thank you. Huh? Okay, I'm Brittany. And I did my presentation on Clostridium perfringens, if you couldn't tell by the clip that you have. So I basically summarized my case file, and throughout you're going to see the treatment and the symptoms and everything that goes along with Clostridium perfringens. So basically I had an RN, and she worked in the hospital, and her main patients were diabetics. And what she did, part of her job was wound care. So she decided to go and get her wound care certification, and it took her 2 years. So Mr. Jones was her first patient, and he was a chronic diabetic. He was blind due to his diabetes, and the reason why she was working with him is because he had a chronic wound taking up half his lower leg. So he was admitted immediately, and he started antibiotic treatments, and he was in danger of losing that leg. His infection was circumferential, which means it covers the entire lower half of his leg, and it was severely infected. So after admission, they realized immediately that antibiotics were just not doing much for him. So what they did, they looked at it and they said, wow, this is gas gangrene. And they did his wound cultures, and they came back positive for Clostridium perfringens. So some information on Clostridium perfringens: it produces toxins, to be specific, alpha toxins. It destroys muscles and tissues, which is, this diagram is a great depiction of it. You can see the Clostridium perfringens attacking the tissues. And it can result in sepsis or death. And it can be death of the actual human itself, or just the lower part of his leg. It could be gone. Mr. Jones went into surgery immediately. His wound was debrided, which means they just removed the dead flesh. Large doses of penicillin were administered, and he did hyperbaric oxygen treatment 45 minutes daily. And that hyperbaric oxygen treatment machine right there, that's what that is. So he stayed on antibiotics until he was clear of Clostridium perfringens, and he got to keep his leg, which is great. So Clostridium perfringens is a bacteria, if you didn't know, and it's found in soil or the normal biota of your intestines. It produces alpha toxins, as I said, and these toxins destroy tissues and they release a gas. That's why it's called gas gangrene. So treatment for Clostridium perfringens: debridement, which they did, administering penicillin, which they did, and then often amputation. In this case, he got to keep his leg, so they didn't amputate. And then hyperbaric oxygen treatment is very important when you're dealing with this anaerobe. So some more about hyperbaric oxygen treatment: it increases concentrations of oxygen, and this increases the oxygen-free radicals, which decrease the amount of bacterial growth, and they also enhance antibiotics, and they inhibit the alpha toxins. So extra details on Clostridium perfringens, I got this from the CDC. It's a spore-forming gram-positive bacterium. It's an anaerobe. And also has a different presentation. Food poisoning, I'm sure you're all aware of what food poisoning is. It's pretty gross. And usually immune-compromised people are affected: 65 and older, pregnant women, young children. So yeah, these are my questions. Is Clostridium perfringens an aerobe or anaerobe? Yes. What is an example of treatment for Clostridium perfringens? The other strand of Clostridium perfringens mentioned causes what? And then this one's tough. What type of bacterium is Clostridium perfringens? It's the spore-forming gram-positive bacterium. So yeah, and that's all the answers. I know. And then, do y'all have any questions? If so, ask Ms. back, because I just told you everything I know about it.
Really good.
And that's why we're excited.
That's really great. Do y'all have any questions? I've acknowledged.
Yeah, I have extras if you want.
So that patient was really lucky
Yeah,
not
he
having
was
to go
lucky.
through amputation for that. Sarah and Brittany, thank you guys so much. This was just sort of reinforcement of some things that we've been talking about, but really good reinforcements. Because anytime you can see case files and applications, I think are great. Y'all have any questions for them?
What was number 2?
What was an example of
Of a treatment. Yeah. So she talked about antibiotics. Penicillin it's very, the good news, it's very sensitive, but why wouldn't you just want to do antibiotics? Yeah, because how are they delivered? Through what? Bloodstream. And is blood getting to those dead tissues? No. So you can't just do that, but of course that can help prevent sepsis. Well, they can give other, I mean, obviously, there's other antibiotics, but I said the good news about penicillin is that it is a inexpensive, easy to administer. You can get good achievable serum levels with that, but you can give, a lot of people are allergic to certain meds, and so you have to give an alternative to those, obviously, because you can't give meds to people who are allergic because that will kill them, right? So those are great. Those are great. And I'm looking forward to the rest of you guys, your presentations. Do I have any questions about those presentations? Here's what I have a question about. Where's my stuff? Here it is. We were on chapter 16, I think, and then we're going to 17. I'm going to go ahead and open that, even though it seems like it took me forever to do it. So, today, are you all right?
Yes, ma'am.
So guys, before we start today, I do want to thank Sarah and Brittany. I think sometimes it's hard to be the first ones to go, but you guys did a great job, so I appreciate that a lot. But let's since we're in the last couple of weeks of this class, just to make anxiety levels go down a little bit, let's make sure we know what's happening in the next couple of weeks, okay? So I am going to put this recording up. I am going to use their presentations and maybe ask very similar questions to the ones they asked you. Sarah and Brittany, I may just change wording around a little bit, but it's kind of the same questions. But we'll also have a lecture quiz that would include some of the questions from their presentation. So a lecture quiz on Wednesday from what we do today, what the presentations were today. I'll put up a discussion board so you guys can do a study review if you can do that and use that too. And then just to give you an idea about what's happening here, the last day of this class is 2 weeks from today. So on that last day of class, we will have a final test that day. There will be a final test that day, okay? That will be, and we'll go over it more as, maybe in the next week or so about what this will be. But you all, if you haven't noticed already, this chapter 16 all the way through the rest of this is really going to be a little bit like what you all are presenting, your case files. We're going to be talking about organ systems and these microorganisms. So looking at our list, if you haven't got your list in front of you, it'd probably be a good idea to do that now. And this final test is going to be a whole lot like your final exam in here. Because what are the questions on your final exam coming from? Exclusively. Exam on what? Hold it up for me. Hold it up for me, Jenna. The final exam is going to be on that. But this is very much like what we're doing right here for the final test. Do you get what I'm saying? So you should be really spending a lot of time with what? Yes. You really need in the next 2 weeks. What'd you say?
Same day or different day?
Different day. So the final test will be on that 29th. On the 29th. If somebody, but that's all we'll have that day. So if somebody would also, yeah, but I was going to say, if somebody wants to, they can stay that day and take the final exam if they feel like they'd be ready for that. But if not, then the final exam would be Wednesday. Okay, now I want to offer this just because I'm here. If somebody, I don't know if you all have Fridays, but if I will be here also on that, wait a minute. No, I have to back up on that. No, I wouldn't. Wednesday, the 1st. But if somebody really, really wanted to take the final exam in here the next Monday, what is that next Monday? That's my birthday. Okay, but yes, on the 6th, they could at 9 o'clock.
But you have to bring her birthday present.
No, you don't, and I can't accept it if you do, so don't bring me birthday. No, but thank you though, because I appreciate that, Jenna.
So if you want
And I'm off of sugar too. Like I'm off of sugar. That's probably not gonna last till midnight tonight, but it's starting today. I'm supposed to be off of sugar, so don't bring me anything.
If we want to do it the 6th, come in at 9.
At 9 o'clock on the 6th, if you would want to. But you know, the final test will be on the 29th. Okay, the final test, and will it have a lot that is really like the final exam? It really will, because I think you all will notice that what we're doing in the next 4 lectures is really just reviewing this list and talking about these diseases. Yes.
So like the oral test, we're going to do like chapters 16 and 17.
Yeah, we'll talk about that. Yeah, but it will be from that. It'll be it's only what we've talked about, won't it be? It's just what we've talked about. Yeah. Might include a little bit more than that though. Some of the immunology. Okay, so just wanted to give you all a heads up on that and let you be aware of that. So does everybody recognize what that was, right? We had just talked about it. Yeah. Yeah. I'm sorry. I have it, so we can do that today at the end of class. If you have not signed up for when your presentation is going to be, and it's counting as a test grade, so that I hope people feel comfortable and casual about this. By the way, I do have a clicker for PowerPoints, so if you would like to be just sitting at your desk, at your table, you don't have to be up here the way that Sarah and Brittany were, but thank you all, whatever. But if you would want to just sit and do it from there, that's fine too. You'll have a clicker. All right. Janet, you have a question?
I really don't like the one I chose. Didn't find anything that I really liked that would make a good presentation.
Which one did you have?
The irritable multiform.
Okay, so if you want to, we'll talk about that after class. It's fine. Yeah, because if you look at your chart, if you look at your charts, there's tons of fun things that you could do. So yeah. Yes. Yeah. All right. So will somebody help me know? I think Brittany, you told me that we end it with what? Do we know where that is? On what slide? And leishmaniasis, I didn't, and anthrax. Okay, so ringworm. So we were talking about fungal infections. What's a term we use for fungal infections? Well, dermatophytes cause fungal infections, and we said that we usually talk about these conditions as tinea infections. Remember that? So if you hear that term, you'll know that you're talking about a fungal infection. Well, treatments would have to then be what? Antifungals, which when we think about antifungals, what do we think about with those? Yeah, so we said that antifungals are going to be much more toxic to your own tissues, right? So the therapeutic index has become much lower on antifungals, so you really want to know what you're treating. The problem comes when people get treated for things that they don't have. So not only are you not taking care of the issue, but oftentimes you're actually causing harm, right? So this entire class, I hope that if nothing else, that's really been sort of what you get is the main points of this class is that when somebody has an infectious disease or a disease that's caused from a pathogen, a microorganism, it's just vital that you get the correct information and that you know what you are treating. So this is what we are definitely, stressing here. So I talked about mycosis. So if you hear the term mycosis, you know that this is referring to a fungal disease. And sometimes these are localized, right? Localized or even cutaneous, which means to the skin. And sometimes they can be systemic, can't they? So we're gonna, as we move through these different organ systems, talking about the respiratory system, whatnot, we'll talk about systemic mycosis as well. But right now we were talking about cutaneous and of the skin. We said that we refer to them as tinea diseases, right? Tinea pedis would mean athlete's foot. Everybody good with that? So these are just some of the things that we refer to them as. Now, when we're thinking about the eye and its defenses, what we know, we talked about immunologically privileged, haven't we? Or did we talk about that concept? Immunologically privileged. What does it mean? Who remembers what that means? Exactly. So the eye and the central nervous system are considered to be immunologically privileged, meaning that the immune response is going to be limited. Because we do know that the immune response sometimes actually can cause damage, can't they? And cause something to not function as well as it should. So these are going to be two areas that actually have this. But we do have built-in mechanisms that protect. So with the eye, we have the conjunctiva, which is a vascular membrane that actually lines the inner eye and the eye itself, except for the cornea. So when somebody has conjunctivitis, this is inflammation of that conjunctival membrane. And their eyes are going to appear really red because you're going to see more blood coming to the side, and you're actually going to be able to see vessels in the eye. If you've ever seen somebody with bloodshot eyes, what you're really seeing are the vessels in the conjunctiva. That's what you're seeing. And if you pull the lid down, is it just going to be fire engine red sometimes? And it's going to be swollen. You're going to see the vessels. And conjunctivitis can be caused from a lot of different things. It's usually allergies. Then viruses are the next most common cause, and the rarest is bacterial. Yes, Jenna?
Sorry, this is kind of a weird question.
No.
But like, marijuana makes your eyes really red. So is that
Yes, it
kind
does.
of like the same thing?
Yes, it does. What'd you say?
Is that kind of like the same
Yeah,
thing?
so it's actually affecting those vessels of the eyes, and this is why you see people who have those eyes like that. It's causing vasodilation in those vessels.
Why would you do that?
I don't know the actual, you could call it pharmacokinetics because it is a drug, right? And how it's affecting those vessels, but it does do that. It causes the red smoke and cause that too. So I don't think it's just the smoke though, or we would see all smokers having those kinds of, right. So I don't know if it's the THC and how it's actually affecting, but it'd be an interesting question to see, to find out about, because we all know what that looks like. Admit it. So okay. And then we have this cornea, which is a transparent, which is that clear, absolutely transparent, multi-layered section of the eye where light rays have to be able to come through, right? So, it truly is called the windshield of the eye. And this is a protected layer. Most of you guys have had anatomy and physiology. Most of you know these distinct areas of the eye, but if I haven't talked about it in here, I won't ask you about it. Right? So I don't want people to feel insecure if you haven't dissected an eye, but I think a lot of you all have, and so you know about these particular areas. We know tears are incredibly important, that we have enough tears. So if you don't and your eyes become dry, they're going to be much more at risk for infections. So there are some diseases we know that can slow tear production down. Sjogren's is an autoimmune disease that can affect the lacrimal glands. Sjogren's, everybody has heard of that one. Sjogren's. Sjogren's is an autoimmune disease, not an infectious disease, but an autoimmune one that can actually cause tear production to be decreased. Is when your own immune system is attacking your lacrimal glands and your salivary glands. So salivary production goes down too. And then that can set you up for these secondary infections that can actually happen, right? Because we need those tears. We need those tears constantly being produced, constantly rinsing across. They have antimicrobials, they have IgA antibodies. all of these things are very, very protective. Has anybody ever had a corneal scratch or tear or an eye? So it's incredibly painful, right? Because there's lots of nociceptors. What are nociceptors? Pain receptors in the eye. And, you know, that's protective because you want to know if something's in your eye that could potentially scratch. So, you know, you take care of it, right? But supposedly really, really painful. And contact wearers are much more at risk for, how many of you wear contacts? Wow, that's kind of a lot. Okay, so
as bats.
okay, but so contact wearers are going to be much more risk. So they go through, you guys get training, right, on how to take care. You don't get training.
Sort of. The doctor just tell me what to do.
But they explain to you that if you don't take proper care of the contacts, that could set you up for infection. They tell you how to take care of them, right?
No.
When I was getting finished,
Okay, well, they should, because there's a lot of things that can actually happen. You know, contact wearers are much more at risk for eye diseases than other people because you're putting something artificial in your eye. So kind of makes sense. But anyway, those are the glands. These are the lacrimal glands secreting tears that wash through. And usually, I mean, you don't even notice this is happening, but the extra tears that are there that are being, you know, replaced are actually kind of moving down through your nose. This is why if something's causing you to produce a lot of tears, they not only can spill over, but what will happen? Your nose will run, right? But this is also why if you have rhinoviruses, which are going to be viruses that attack nasal tissue, and or allergies that cause this is also why your eyes are affected, because you can also have backup into the eyes. Yes?
so you have like a sty.
So styes on the eyes are usually caused from folliculitis. So do you know what a follicle is? It's where the hair is, right? So it's usually that you've got inflammation of a hair follicle and it becomes inflamed. And it is usually almost always because of Staphylococcus aureus. And that's on your sheet, and I do want you all to know. And thank you for mentioning styes because, you know, some people are really prone to having styes. Has anybody ever heard of an old wives' tale treatment for that? No. What was the question?
I know, like when I played softball athlete all the time.
Right.
I had them all the time.
Right.
Dirt
Would come up and get in, and it would block. It would probably block a little
It's really
pores.
worse. Like my dad does them as well.
Yeah.
It's a lot. And there's awesome.
I
I don't know who's supposed to do that. He's just a man. It's awesome.
He's just a man.
He's just a
She
man.
said. So I think women sometimes can be bothered too. But okay, guys, why, especially in your face, y'all know this is called the death triangle. Do y'all know why that is called that? Oh, it's called something else too, but we always call it the death triangle. Because if you're pressing things in this area, especially so close to vessels, blood vessels, and what is really close to this area? Your brain. So, you know, you probably aren't supposed to, especially, you know, do that for things in this area. And it is Staph aureus. They're usually almost always caused from Staph aureus. Did you have a question? And I do think some people are a little bit more prone to having them than other people. Is probably because of the way their eyelashes are, you know, so, and just the way the hair grows on eyelashes. So anyway, but they usually begin as a follicle or pore becoming infected or whatever. So, but conjunctivitis, most commonly caused from thin viruses, thin least bacteria. They usually present very differently. Those three types of causes for conjunctivitis are going to present very, very differently from each other. The secretions are going to look really different from each other. You're going to have with allergies just a lot of redness, a lot of secretions that may be kind of goldeny, but not really. It's sort of clear looking, and a little bit of swelling. But and even more maybe with viruses or whatnot. But with the bacteria, you're typically going to see like purulent, cloudy, greeny, yellow goop. Okay, not just a little, a lot, and a lot of swelling and a lot of pain. Yeah.
What was the order of those again?
Allergies, viruses, then bacterial. Okay. So, and this talked about the immune privilege that we had said. So we usually think about, I know they give you a little list of microbes in the eye, but most people that have cultures of their eye done, nothing will grow. It's you know, the tears are pretty much doing their job. So, I mean, if you really get it, is this just like going without me? If you really get a, you know, if you really get a good enough sample, you might get some of these that we think of as being just normal skin flora, but typically nothing is going to really grow. And that's how we like it. So eye injuries are just going to be, obviously, people are going to be really at risk for having an infection that can then scar these important structures. And if any of the, especially like the cornea is scarred, is that going to impair your sight? Yes. Yeah. So, you know, that's what you're kind of hoping is not going to happen, is that you're going to have any kind of scarring on those because of damage or injury. All right. So, I talked to you about the different types. I'm hoping I did. Oh, so people call it pink eye. In infectious disease and ID, we only call pink eye the bacterial ones, but the people call pink eye just when your conjunctiva gets red. You have conjunctivitis. What happens when somebody has conjunctivitis, or as far as like treatment stuff? If you have a child, maybe you have children, you have a child, you have conjunctivitis, you take them in, and what do they have? What are they? And there are going to be antibiotics, aren't they? They're going to be drops, and they're not allowed. You're not allowed to go back to daycare, school, or whatever within 24 hours of having, you know, getting these. And so they're going to require that. Is that kind of an overuse of antibiotics? It really is, but sometimes we said we use antibiotics to be prophylactic. What does that mean? Yeah, so sort of prevent something else from happening. So sometimes that's okay that is actually happening, that you do that. We say we get that happens. As far as neonatal eye infections, the two are going to be the ones that we think of as being sexually transmitted organisms, because this is when the fetus, the neonate, is being introduced to this as they're moving through the birth canal, the vagina. So in the world today, the #1 cause of Lyme still is chlamydia trachomatis. It's asymptomatic in most people, isn't it? So people don't know they have this. In developed countries, you can be tested and, you know, you can be screened to make sure that this isn't happening. But also in developed countries, we know that neonates are getting drops in their eyes, aren't they? Erythromycin drops in each eye within a certain time of being delivered, they get those drops. And that means that the numbers of neonatal blindness have really, really gone down. Herpes simplex, this is going to be also something that can cause scarring. So y'all can look up. Nobody has this, do they? As far as their case study, do they?
Oh, I think we're asking if we have.
No, okay, it probably sounded like that. Any of y'all have that? No, I wasn't. I'm sorry. Thank you. Thank you so much. No, it's like, does anybody have that as their case study? You know, Janet, this would be a really good one, is case studies, because you're going to be able to find like numbers of incidences, and you can do worldwide, you know, or look at our country, do our country numbers, whatever, show some pictures, show some treatments. So, you know, this can definitely be, but it's not just herpes simplex because of babies, neonatal. We can also have varicella zoster, we can have shingles in the eye, and even herpes simplex in the eye as adults. I've seen so many adults come in, like I truly, a couple dozen at least, seen adults come in with herpes in their eye. And so, you know, they're telling that it's incredibly painful. It's usually a pretty easy diagnosis because you can actually see the lesions on the eye, and it can lead to scarring, and it can lead to loss of vision in that area. Well, you know, it's herpes simplex, obviously coming through the birth canal. It can happen. But as adults, you can get it just from touching. You can transfer it from a cold sore to your eye. I mean, you can transfer it from in different areas on your body to your eye. This is not an uncommon thing. You all will see this if you work in any ERs, and you'll see herpes simplex in the eye, and it's really painful. for these people, and the worry comes that it can be reoccurring, and then with the reoccurrence, every time there's an occurrence and an outbreak, it can lead to scarring, and that scarring can eventually lead to sight loss or whatever, you know what I'm talking about. So anyway, these are just some of the microbes that can cause conjunctivitis and whatnot. So we said usually no, it's not usually bacterial, is it? It's usually allergies, then it's going to be viruses, and then it's going to be bacteria. So okay, conjunctivitis. And y'all can see some of those things. Okay. This keratitis, this is going to be invasion of much deeper tissues, and so blindness is something that can happen. So this is the one that we want to avoid and prevent, and hopefully, hopefully this is the one you're going to catch this early enough, try to prevent whatever is causing the infection, because it's not just herpes simplex. There's some others too, but you're going to want to try to prevent the damage that's being done here so it won't lead to blindness. Okay. There is a amoeba. This is an amoeba. I've never seen this myself in a patient. That doesn't mean anything. It's one that I haven't seen. These amoeba live in tap water, fresh water. These are the ones that they really do talk about with contact lenses. If somebody, would you make sure that you get a slide on this one, Janet? Amoeba, because this is what I was telling you about contact lens wearers really need to be careful with this. Because I have had friends who not only just rinse it in tap water, their contact lenses, I've had friends lick them, and I've seen that a lot. It's just where people will put them in their mouth and let them around, I've seen a lot of athletes do that because they drop them and that they find them is amazing because you're in the middle of the game, so whatever. And most of the time it all works out well. Amoeba? It's an amoeba, so you're looking on your protozoa, you're not looking at bacteria, right? I think it is.
Yeah, it is.
Yeah, so I would have been sad if I missed it on your sheet. But anyway, at the end of each of these chapters we're about to do, guys, look, you had this, which I think is just really nice. It's almost like another little review of you for some of these microbes. Do you all see that these last few chapters are really kind of your sheets? And talking about these diseases. Okay, so good. So here we go. And your presentation. So it's all reinforcement of these topics. Now, the nervous system. Some basics of the nervous system. You all remember that when we talk about the nervous system, we usually think about the central nervous system, which includes what? Brain and spinal cord. And we know the central nervous system has this immune privilege. Again, but it's really protected, the central nervous system. It's protected by bony structures, so spinal cord and brain. Think about that. There are these bony structures, but also membranes. And what were the membranes called? Meninges. They're called meninges. So you got these three separate membranes. You got a bony structure. You got these three separate membranes. And they're very, very protected. But then you have the peripheral nerves as well. And the peripheral nerves are making what makes up the peripheral nerves. The nerves that periphery means what? It's on the periphery. It's on the edges. It's on the so beside, right? So when we think about peripheral nerves, we mean those nerves that are coming off of the brain and spinal cord, and that are coming to the brain and spinal cord. Remember, we said there are 12 pair of cranial nerves that make up peripheral nerves, and there's 31 pair of spinal nerves that make up.
Well, that's the thing. There's like a medical website, and this lady, she died from cancer, and she wanted to be brought back to life, so they preserve their body and froze it with liquefaction sugar and stuff like that, and then they try to run blood back to their body. I didn't understand if you guys find that's life, and I mean they did it. They said they'll probably never be able to figure out how to do that.
You mean they preserved her, but they didn't bring her back.
No.
Somebody said, okay, so they preserved, okay, so they're trying to preserve. Yeah, there's, So, you know, people, this is really an important topic, actually, about death and end of life. And, you know, this whole idea about should we be living forever, right? So medicine has really taken us a long way, and we've doubled our human lifespan. Right now in the United States is the first time that lifespans are beginning to actually have decreased a little bit by a couple of years in the last few years. But in a very short period in our past, we doubled human lifespan. And this is through modern medicine. This is through science and modern medicine. But a real conversation needs to be had about, and needs to be discussed about death and dying, and you know, whether we want to be preserved. There's some very wealthy people who are doing things like preserving their heads when they die, because they're thinking that if they haven't preserved the whole body, but preserving heads, so in case science comes up with in the future the ability to bring somebody back, there would be the cells there, and hopefully their head. So, you know, you have to really, there's so many topics that we can talk about related to that, right? And when you hear about medical costs, because right now most people cannot afford most people have to think about whether they're going to have a test done to screen if they had something, and they may have signs and symptoms for it, but they can't go and get tested, or they're not going to be able to pay another bill this month. Most Americans are in that situation. Most Americans are living in that situation where they're making a decision about, you know, having medicine this month or being able to pay, you know, for food, right? So it's a serious, serious conversation issue, especially when you consider that medical costs, most of the medical costs happens to keep people alive in the last 6 months of their life, last 6 months to 3 years of their life. And the quality of life in those last few months, I mean, let's just face it, people, it's not there. And that's where more than half of our medical expenses are coming from. So there's a lot of conversations to be had. There's a lot of regulations that are going to be discussed and talked about. We're all part of the conversation. So people need to really be thinking about how they feel about that and extending life those last 6 months to 3 years. When I say, is it worth it? I think life is very much worth, you know, whatever, but okay, but what are we doing at this point? Like, do we understand that there comes a point that death is as essential to life as any of the other developmental parts? But there's such a fear of death in human beings. There's such this fear, not in all cultures, but in most religious cultures. There's such a fear of death that these extreme things are happening. But there needs to be some open conversations about it. I wish we had time to do it. I really do, because those costs, you guys are all paying, including myself, we're all paying these costs, all of us, and medical expenses and costs. We're all paying for it. And there needs to be some rational discussions about that, I think. Y'all are going to see it. If you go to a level 1, any kind of level 1 care facilities, not local hospitals, but level 1 care facilities, you're going to be seeing people kept in states of whatever for a very long period of time. You know, you'll hear conversations being had with families that, you know, we can keep your loved one going for a long time, but what are we doing, right? Mm-hmm. And family members who can't make the decision and won't make the decision, and I don't blame them. It's a hard decision. But what it really needs to maybe come down to are people making the decision when they're rational, you know, for themselves, and taking it out of the hands of the loved ones. So y'all know about living directives, right? And living wills and those types of things. We should all have it. Even young people, you should have them, right? Because we're doing things that, like I said, if you go to a level 1 center anywhere, UVA, Duke, Carilion, any of the ones that are level 1 centers, you're going to see people kept in situations that you wouldn't keep your pet in that situation. Casey thinks I'm terrible for saying that, but you wouldn't, Casey.
My dog was walking there with no eyeball.
With no what?
My dog has no eye.
Okay, but maybe your dog has everything else fine and your dog's happy. You know, there are people who can't see. I'm not talking about that. I'm talking about people who have almost no brainwave activity and open sacral ulcers and vital signs that are showing that they're in excruciating pain, but family members won't make decisions. For weeks and months. Weeks and months. Janet knows what I'm talking about. Janet's like, so you, where, okay, you think you see it in nursing homes, you should see these level 1 areas or ICU, where they're kept in ICU. We can keep people going for a really long time.
A year ago, one of our friends,
I don't know how this conversation started.
they told us that
Molly,
he had liver failure.
Yeah.
And 6 months ago, they told him he was brain dead. But they kept him alive this whole time, and they finally told him.
So those 6 months probably cost somebody, us, a couple $1 million.
Yeah, and they told him that they couldn't do anything else for him, but the family wanted to just keep him, you know.
You know, and so y'all, I don't know the answer. It sounds like, am I sounding opinionated about it? Here's what I'm sounding like. I hope that y'all see it, is that death, I think death is normal. And is what?
It should be normal. It should be normal, but it's not normal.
It's not normal because of fear. Because of fear and because of whatever. I think that it becomes much harder when it's a young person, but when it's an older person, and I'm included in this, I hope the conversations are really open that, you know, it's a natural part of life, and be happy when you think of me. I hope you'll all be happy when you think of me, you know, because I'm really ready and satisfied and whatever. But people can't have those conversations. How many of you know people who just won't have those conversations? Exactly. How many people raise their hands? Exactly. So living directives, yes.
When people do not have the do not receive there's this man had cancer for a while. He CPR on a burn bag, lived for 30 minutes, broken ribs, absolutely no pain for 30 minutes.
Yeah.
That's all he lived. So why would he sit there and break ribs and make the person suffer just for the
Work in any PCU, ICU in a level 1 center, and you're going to think that was a good way to go. There's some weeks and months that go on. So when your healthcare costs are coming to keep people in that last, more than half of your health are coming to keep our costs for that, there needs to be some conversations. There needs to be some. And they're tough conversations. They're really hard conversations, but they need to be them.
I was doing my RN shadowing, and I happened to be in med-surg.
Mm-hmm.
And there was this lady there. She was in her late 90s, and they had her there to die. There's no other way to put it. That's not one word.
Right.
And it was bad because she'd been there for about 2 weeks. They wouldn't give her morphine because the family said no. And and because they were scared it was going to take her out faster.
And it does.
And which they do.
It does do that.
And I come to find out that the family hadn't even been there in 3 days. So like at the end of my when I was done, I like putting the sat with her for a while.
Oh, good. You know, because honestly, a lot of, as far as senses go and whatever, they know hearing is one of the last to go. So
she was able to like open her eyes and ask her. She had like crystal blue eyes.
Mm-hmm.
It was the prettiest eyes I've ever seen. And come to find out, it was me and one of the nurse she only opened her eyes for.
Yeah. So she was sensing something, you know, that. And, wow. Okay. Wow. Yeah. So it's kind of a different class, but not really sort of the same conversations, you know, that you guys are really going to need to be part of, rules, the regulations that are going to go on.
They wouldn't make it go faster because she was in pain, obviously. She couldn't talk or anything. She only really opened her eyes, and they still hadn't come to see her in 3 days, and they were forcing her to.
You'll see people in these areas that have the entire peritoneum is open, or, you know, whole things are open with irrigation happening and pumping and, you know, tubes and no communication available because of vents and yes, so, and it can go on for weeks and months and months. Conversations. So, Michelle, did you have something? Did you have your hand up? Oh, no, I thought you did. Okay, so we'll get back to this though. So we know that we know the basic anatomy of the central nervous system. I think everybody kind of remembers that. So I won't go over the anatomy too much because I do think you guys remember that. But I do want to talk first about meningitis. So when we talk about meningitis, some of the things I want you to know is that this would obviously mean inflammation of those meninges, those layers that are surrounding the central nervous system, the spinal cord, and the brain. When we think about meningitis, if we're looking for good news, I mean, because that's not a great prognosis, is it? But if we're looking for good news, the good news is that it's usually because of viruses, and it's, you know, by far and away, it's like, you know, they'll say 5 to 1, sometimes you'll see 7 to 1 meningitis cases are because of viruses, not bacteria or other. And by the way, protozoa and fungi can also cause these, but it's usually viral. And the good news about that is that most of the viral is going to have a lower mortality rate. So you're expecting a better outcome from a viral meningitis. And usually when we think about meningitis, we think about these better outcomes for viral meningitis. It's not usually so contagious. So you're not having to isolate, you're not having to take prophylactic drugs if you came in contact with people. And so that's actually a good thing. When we think about diagnosis, it's going to require lumbar puncture, which is what people call spinal tap. So this lumbar puncture is going to be performed at the base of the spinal cord, which is usually below L1. Do you remember what L1 means? The first lumbar vertebra, so you can go below that, because we know the spinal cord ends around L1. So you go below that, and they go into this space and get spinal fluid from the area, and then they're going to look at the chemistry of it, the hematology, look for cells. There shouldn't really be detectable cells. The chemistry, we know the normal levels for glucose and protein, so we're not expecting to see protein be high and glucose low, because that could indicate infection. And then the cultures are done, and then also some serology tests are done. Some of if you suspect meningitis, you're going to start with broad spectrum, because you can't afford to be wrong, okay? Cannot afford to be wrong, so they're going to start with broad spectrum antibiotics, which have a lower therapeutic index, but you can't afford to be wrong in what you're doing. You've got your samples before you start the medication, so that your samples, when the answer does come back, can you then narrow your drugs down? Yes, so that's the whole thought of that. And these are some of the signs and symptoms. With this particular meningitis and/or encephalitis, the symptoms are going to be acute. They're going to come on quickly, and they're going to usually be serious. The temperature is going to be very high. The pain, there's going to be a headache. And it's not like something that's just, you know, they say it's not describable. Stiff neck is very common. So in little kids, they don't really know what you mean when you say is your neck stiff, but you'll get them to do the nose to the knee test. And, you know, little kids can do that really readily, can't they? But for adults, you can ask them, you can watch them, because sometimes it might have happened that they're not even realizing that their neck has become really stiff, right? So these are just some of the things. We also know that nausea and vomiting, really? Oh, I didn't even do that. Just hit it? Okay, so I don't know. Nausea, vomiting, these can all be signs of it. Sensitivity to light, and then certain bacterial causes of meningitis will cause a very distinctive kind of rash. And so those rashes can be something that we're really looking for. The TPO rashes, they're referred to because certain of these microbes, especially Neisseria meningitidis, do you remember that one that causes meningitis? Well, it's actually in young adults, but it can also be in babies. So we think about Neisseria meningitidis as young adults. This is why, you know, the CDC is requiring even middle school age kids to get the meningovax vaccine. But anyway, this is one that actually can affect the blood vessels and can cause rupturing, and you can see these little tiny bruisings under the skin. So if it's usually starts on the trunk and can go to the extremities. But these can all be signs and symptoms of that. And some of the bacterial ones are going to definitely be associated with epidemics. So this is why once diagnoses come in, if it's one that we associate with epidemics, anybody who's had any exposure will prophylactically be treated as they should be. That makes sense to everybody? All right, so you guys have heard of this one, right? Neisseria meningitidis, that's on your list. It's bacterial, so we know that. We know what petechia are. If you don't know what petechia are, I just put that in red so that you would know. These are those little bruising, because it's bleeding under the skin. Has everybody seen petechial rashes before? Well, has anybody ever vomited so much that you saw these little spots in the thin skin of your eyelids? Have you ever seen that? That's some serious vomiting. If you've done that, you've never seen that, okay. Or after labor, child labor, if you push for longer than like 30 minutes or something, you'll see women who have petechial rashes because of the pressure that they've exerted pushing. No? Okay, Google it. Google it. What you say?
Google it.
Well, that's from pressure exerting, from vomiting, whatever. No, but the petechial rash that's for meningitis is usually starts on the trunk, and they're like little purple. They're like little purple dots almost. I do want you all to Google it because once you see petechial rashes, you'll know them. So these are the kind of things that when you see on somebody's trunk or extremities, you should be paying attention to this. You should definitely be paying attention to something that could be causing these blood vessels to be lysing, to be splitting, breaking, right? Anyway, so this is one that we really associate with Neisseria meningitidis. We also associate petechial rashes with Rocky Mountain spotted fever. Yeah, have y'all ever, that's why we call that spotted fever. And you'll see those petechial rashes on even the palms and the soles of the feet. And, you know, that's something to be concerned about when you're seeing those. If you're seeing them around somebody's face, it's just maybe because they've been violently vomiting. Who knows, maybe they've been drinking too much. I don't know. You don't worry about it as much on the face, but on the trunk and the extremities, you do worry about it. All right, so these are some of other things. I wish we actually even had more time. But we said the highest risk, obviously little kids are always at risk, aren't they? But it's going to be usually young adults. And now they push this down right down to 10, 12 years old. So this is why CDC has said to get this meningitidis in, and usually by middle school. So college dorms, daycare facilities, school classrooms, military bunks. But we see many less of them because of the vaccine now. Has everybody had that vaccine in here? This has a high mortality rate. You'll notice that this is with treated, even treated.
Wait, what? Not the. I thought you meant the vaccine. Oh my God!
No, this is with the vaccine. We've seen the numbers go down. We've seen the numbers go down, but we understand that this is an important vaccine because this one does have a significant mortality rate. Okay, so you guys can look at some of these different bacterial causes of this, but are they the most common? No, it's viral. But do look at these and just look at some basics of those. If it's not on your sheet, I won't ask it of you, will I? Streptococcus pneumoniae is actually probably in our country right now the most common bacterial cause. It can affect any ages. And these numbers are going down now. Why do you think? Why do you think? Yes, because now we have a vaccine that's it's part of the pediatric protocol, the pneumovax. And there's a couple of different pneumovaxes for the Streptococcus pneumoniae, but again, we're expecting the numbers to go way down. I had somewhere in here, and I'm trying to think where it was. I highlighted it on the PowerPoint so you could get to it. But I had the numbers of the people's lives that have been saved since these vaccines have come on. And this is just in our country. So it's going to be really important that people understand about these particular vaccines and their availability. Did you all see on the news this weekend about social media sites are trying to really crack down on misinformation about vaccines? Are you seeing that? Because there's so many sites, and one of the sites they really that they really are cracking down on, and they're pulling it from their social media, like Facebook. What are some other social media things? I don't know. Yeah, all those things. They're pulling them. One of them started with healthnews.com. Now, when you saw that, would you think that it would be legit? You would? Okay, y'all are more excited. Huh? Okay, so anyway, but sometimes they start with things that are misleading, right? So there's just so much misinformation just being pushed out there that is so scary about vaccines. And you can see where people would be afraid a little bit if they thought this was true. So they're trying to really be better about that because, of course, all those scary stories get shared much more frequently. They know that too from these algorithms, how quicker they get spread than real news. I sort of think of that as like Fox News, so it just gets spread. That stuff gets spread so much faster than actual real news. So it's going to be important that you guys be part of that and sharing with people about how important these vaccines are. This prior to the vaccine in 1988, y'all are thinking that's before I was born. That was so long ago. Guess what? It could happen again. It could happen again. I saw these people die. I saw them in our ICUs. And so, just cannot tell you how important it has been to see so much less of that now. It's become a rarity instead of the norm. And so let's hope we can keep all that going. For that. Yes.
So I had bacterial pneumonia my senior year in high school. Am I like scarred for life? Like my lungs don't have the same like capacity, and I can't do the things I used to. Like
they
it's
don't
not
have the
capacity. But like, is that true?
Yeah.
Okay. I had double pneumonia.
Yeah, I'll tell you guys. So this is another reason, because we do have people live. They're not 100% fatal, these things. But so we have people live. But when somebody has had these types of events, there's scarring that happens. There's fibrosis that happens. And I had a pathologist once tell me that doing autopsy, you can look at someone's lungs and you can see every time they ever had pneumonia. You could actually, from histology, gross anatomy, and also histology slides, see every fibrotic event that they've had. So, just saying, oh, that's just viral pneumonia, or that's just what bacterial pneumonia is much more serious than viral pneumonia, and the scarring is going to be worse because it is worse. But, that doesn't mean that you should just not be, but it's there. And yes, you are living with it. Your lungs have, there would be noticeable difference because of that. So what we try to do is prevent, right? Try to prevent those types of things from happening. Some things we can't because we live in a microbial world. It's normal to have things, but you try not to have such recurring. This is what happens with cystic fibrosis patients. They have such recurring infections. They almost keep a lung infection. So by the time that they're in their teenage years, their lungs are shot. So this is why they need usually need lung transplants. By the time they've gotten to that point, too much scarring. So Listeria monocytogenes is on your list. And with Listeria monocytogenes, I think I had talked to you guys not so much about meningitis, but I had talked to you about Listeria monocytogenes. The bacteria is causing from food. It can be, we can get it from deli meats, whatever, and it can cause spontaneous abortions, which you all call what? Miscarriages, right? And we know it can do that, but in some people, we also know that this can actually lead to meningitis. And again, when you look at certain ones that are very much compromised, it's a significant mortality rate, isn't it? So bacterial meningitis is just much worse than viral meningitis is. Okay, so I'll just let you all go through that. Now, this is a fungal cause of meningitis, and it's only the Cryptococcus neoformans. So you would have to go to your fungi list. I think we talked about it before. But this Cryptococcus neoformans, this is only going to be seen on immunocompromised patients. So a lot of times this is the last thing that your AIDS patient has. This is what ends up taking them out, right? Is something like this. Again, headaches, most common symptom, sometimes nausea, neck stiffness, and it's a fungus. And I would want you to know that. So, and again, immunocompromised, you all should know that. It is frequently a fatal. So, and it's antifungal after the beginning. Coccidioides immitis. This is going to be one. This is the species, immitis coccidioides. This is, again, a fungal infection. We usually see it in very arid regions. So in the southwestern part of the United States is where we see it most often. This is referred to, I think I have it in your little chart, as valley fever. Do I? So it doesn't just cause meningitis. It can also cause a systemic mycosis. It's the yellow fungal. Yeah. Okay. So this causes a systemic mycosis, and it again has a significant mortality rate. This is one that we worry about sometimes in pathology, because when we get the sputum cultures or samples into the lab, whether it's bronchial watchings or sputum cultures or what we get into the lab and get the stent growing. It's one of the reasons now in a micro lab we have so many regulations about how we handle certain plates and whatnot, because this has actually led to pathologist deaths and microbiologist deaths, because it is that deadly. And we know that when we're dealing with plates, bacteria don't produce aerosols, but what can? Fungi can. And this is why I tell you all, don't open your plates if you have any fuzzies on them, right? But is this one that would be here, native to right here? No, it isn't. So you don't worry about this one too much here. Again, belly fever, this is sometimes called. Now, viruses. This is 4 of the 5 cases, but it's probably even a little bit higher than that. I actually think that because we do think that there's some viral meningitises that probably don't even come in and get seen. Most of them are from enteroviruses, so most of them are going to be from that particular category. But we can see herpes simplex viruses, especially 2 causing this. So in babies, obviously this would be devastating. And this is why some people, if they have had any history of genital herpes, they will sometimes, the OB docs won't risk vaginal deliveries. They'll go ahead and do planned C-sections with this, which is kind of a shame, because honestly, as far as the transmission rate, we do think unless there's a primary infection, which is really the fetus is at risk, they do think that this is not something that probably has to be done. But we know that we have a really high cesarean rate in this country, don't we? Supposedly, if you were really even conservative about cesarean rates, because cesarean rates save neonates and they save women, mothers, right? They definitely do, and they're definitely needed. But in the incidences where they're needed, like placenta previa or placenta abrupta or preeclampsia or whatever might be going on with the fetus, there would be about a 6% cesarean rate, which actually sounds kind of high, I think. But in this country, the cesarean rate's over 30%. There are a lot of things leading to that, like contributing to that. There's some people who are picking their own baby's birth dates and choosing to not have vaginal deliveries. They'd rather have a C-section than vaginal deliveries. Jane's shaking her head because she should be. You know people who've done that, Michelle, too? You've had C-sections. Did you pick your dates and your picture?
No, I didn't think that.
Oh, okay.
I wanted to.
You wanted to. Okay. But anyway, so we do think that in this country it's probably because of litigation. And people are, they don't want any sort of whatever. But it's a very natural thing to have vaginal delivery. That's the most natural thing in the world. And and almost always works out well. It's like OBGYN told me one time, a friend of mine, she said it's either the best job in the world or it's the worst. When it happens, she said usually most of the time it's the happiest place in the world to be until it isn't. And then it's really bad. Yeah.
And then this girl is tired of being pregnant, so she's going to go ahead and get a C-section. She's not due for 3 weeks.
Well, that's not really her fault. That's her doctor's fault, but that is definitely her doctor's fault. I know a lot of people who don't understand that every day in utero is an important day. So just because she's ignorant doesn't mean her doctor has to be. He or she needs to be the one. He or she needs to be the one to call me. That's on recording. Send it to him that I said that. So if she gets to pick a 3 week early date, that's a woman who needs a new doctor. Okay, well that's not her fault. It's not her fault that she doesn't understand that, but it is the fault of the physician that would allow that. It's really not her fault, Casey.
Oh, it's her idea.
Well, it might be her idea, but she would have to have somebody to buy into that to do it. And if she's found somebody to do that, that's malpractice. Which, and I'm saying that, and that's the truth.
No, I'm saying I carried over. Like I don't know a physician that would never.
Oh, I know a lot
have
of
a baby that early.
I know a lot of physicians now that are doing that week before, but the fact is that's wrong too. 40 weeks is full term. 40 weeks. Now, I don't know any that let you go much over that amount, and 42 would be the outside. 42 weeks is the absolute outside, because then things start to go wrong too, you know. But somebody who has physicians that just want to do it before their dinner hour, or physicians that will let somebody dictate to them the date, that's wrong, and it is wrong. It's been happening so much though that now they're public safety announcements on TV, trying to talk to people like your friend who thinks she knows what she's
not as far as long as they think.
Well, that's why there are these public safety announcements now that are saying every day in utero is an important day for your fetus. It really is. So. Don't get me going on that.
I just
Don't get me going on that.
tired of being pregnant. I think everything.
Like, no, I love being pregnant.
Oh,
I did. Like so much. What'd you say?
I said a lot of people I know like being pregnant, and
I love being pregnant.
Obviously, my mom.
I love, Kirsten said obviously her mom. And I love delivery. I love the whole thing. Breastfeeding, I love the whole thing. It's so awesome. It's so natural. It's so wonderful. Maybe it's not if it's not planned, and if it's not that. What'd you say?
all I can think of is like, that in the middle of July.
Oh my God. Okay, that's not bad. Okay, so
Well, you're lying.
Use your head sound something. Please.
So, all right, so here you go. We're going. Come on, we're going here. Sorry if I got off on that. All right, so neonatal, we said, what's the one we think about? Group B strep, then we GBS, Streptococcus agalactiae. Y'all should have that on your notes. That should be one that you're remembering. Now, obviously, there's some other ones that can also happen. E. coli, Neisseria, we talked about being a teratogen, causing spontaneous abortions. We talked about that this can also lead to meningitis. But it's really the GBS. And so this is why in a good planned pregnancy and somebody having good prenatal care, they're going to get screened for that, aren't they? The woman's going to get screened to see if she carries GBS in her vagina, and if she does, it's part of her normal flora. It doesn't hurt her. But if she carries it, if she's a carrier of that as part of her microbiome, then she's going to get an antibiotic when labor begins. And usually it only takes one dose. And that's enough to reduce the GBS in the vagina that the numbers of neonatal meningitis have gone down so much. Again, maybe it's because I saw that transition. I saw where we always had in the NICU and the PICU, we always had these meningitis cases, and then all of a sudden the beds were empty. Over really a few year span when we started doing these types of practices. And that's powerful. The problem comes now that people aren't remembering. So they're not, realizing how important these vaccines, these practices, these very kind of simple practices, how many lives are saved by this? I know I sound like I'm preaching that, and I'm sorry if that sounds that way. This is just sheer numbers, and the data supports that. So take a look at that. E. coli can also be one. I don't think I have. Do I have Conobacter Sakazaki? This used to be Enterobacter Sakazaki. They changed the name. They often do this in micro. It's going to make you a little crazy because some of your microorganisms you're going to be thinking, I know that species, but they're yes.
I don't.
It used to be called Enterobacter Sakazaki. So, oh my God, has had that. But this is kind of rare. But look at the mortality rate. I mean, this is horrible, right? So, whatever. If I didn't have it in there, it's just one that we do know we can go wrong. So this is your chart that sort of looks at a few of them. I'm going to just kind of go through. Do we know what polio is caused by? Yay, a virus, right? So polio is from not yay, it's polio, but that you know that it's caused from a virus. And so we understand that this is a virus that actually attacks the motor neurons. And so sometimes people have very mild kind of symptoms and what not from this, but other times like a mild viremia, viruses in the blood. But other times, obviously, it can cause paralysis of the lungs, and so people can't breathe. They have to be put in those iron lungs. Or it can cause permanent paralysis, motor paralysis, where people are going to be crippled. And this is something that they would then live with. So what we know is that there's immunizations that can prevent this disease. And hopefully with the Bill Gates Foundation and the World Health Organization, this might be one that we see eradicated in the near future. And we had talked about it. So some can be paralytic, some can be non-paralytic, but all of it could be prevented. So there is something I did, and then we'll sort of end it on this one right here with this. There is something, I might have mentioned it to you, but maybe not. Some of your older patients in your skilled care facilities that had been exposed to polio, and I think some of you told me you people who had polio. So they may have a limp, or they may have a brace, or they may, whatever, that had survived polio. There's something now that we're really seeing happening in these patients decades later. And this is called progressive muscle deterioration or post-polio syndrome. It leads to this deterioration. So about 50%, up to 50% of patients is something we should be looking for in those patients and maybe trying to help them with physical therapy with early detection of this to try to prevent some of the loss of muscle mass from this. So polio virus. This is usually a fecal oral route transmission. It can be. So it's very, very infectious, isn't it? So hopefully people will continue to get their polio immunization. We'll stop right here. All right, now look. So there really isn't a lab. I don't have any more labs, guys. I don't have any more labs. Sorry about that. Who is supposed to present Wednesday? Can you raise your hand right now if you're supposed to present Wednesday? I only have 2 people. Those 5 just did their hands. 3 here, Molly and Amanda. 5. All right, we will do it at the end though, instead of the beginning, okay? Unless you want to. Y'all want to do it? Okay, let's get it over with. We're going to do it. Okay, because I know I would hate to be sitting there thinking I got to speak. I would be over here. Okay, so we'll do it at the beginning. We'll get it over with, and then we'll do like a continue lecture. Are y'all seeing that this is just a review of our charts? What are you studying? What are you studying? These charts. The lecture quiz for Wednesday will be just on the presentation, Sarah and Brittany's, and what we talked about today. Lecture quiz, and we got a recording, and I hope that this recording goes through because if there's somebody following me.
I just want to make sure about which chapter I have. I think I have chapter 22. I would like to change mine.
Okay, please, let's go to my office right there, and I've got the list in there. Let's go to my office, and let's do this. Why did this, oh my gosh, is this